Yeah, just my take on things. My answer to number two. Guided discovery, identifying, challenging your beliefs, reframing your mind, negative thoughts release. Those cognitive distortions decrease until they cease. Let's go. Guided discovery, identifying, challenging.
I think we're recording. Welcome back, everybody, to another wonderful episode of Peplow's Ghost. I am your host, Dan Wesemann, and I am thrilled to have another couple wonderful guests here from Georgia, Mercer University. So just talking about before we started recording that we just happened to meet at one of our presentations at NUMF, which again, Melissa's probably going, "Nump, what is that?" That's that's the National Organization of Nurse Practitioner Faculty. So those of you who may be listening and don't know that, but yeah, it's one of our big conferences that we have, and that was in Denver, right, this year. So yeah, so hopefully got to kind of meet and connect with that conference, and Humberto kind of jumped in and said, "Hey, would it be okay if we could kind of continue a conversation?" And definitely invited one of his esteemed colleagues, Dr. Stephanie Bennett here. So at this time, I usually sometimes like to do some introductions, but you know what? I'm going to let you guys do that if that's okay. Just, I've actually had some guests who say they feel a little embarrassed by the intro that I do. So I'm just going to let you guys introduce yourself. But again, really enjoyed you. Thank you for making the time to be here. And as you've mentioned, you've listened to a couple episodes as well. This is really to focus a lot about psychotherapy and kind of the role that psych mental health nurses, nurse practitioners kind of play. So maybe just let me throw that out for both of you and just kind of get us started. What got you interested, or where does your interest come from in doing psychotherapy, or just kind of that in the role within the PMHNP?
Sure. Stephanie, you want to start us off?
I think that as far as doing psychotherapy, it just fell into my lap because there was people who didn't have anybody, and initially you go into being a psych mental health nurse practitioner, and a lot of it's medication management. But so many of the people that came to me, either one could not afford a therapist, didn't have a therapist, didn't have time. And so I fell into it kind of that way, not really anticipating that. In addition, I do go and volunteer at a free clinic some. And so when they lost their therapist, which I'm working diligently to get them one back, who's better than me, but I kind of fell into that as well. And so it was, it was to meet a need. That's how.
I hear that. It's one of those things, and there is a huge need, right? I mean, I think that's one of those things that gets, maybe advertised more than it should. It's, there's a need obviously for people to be able to prescribe psychotropic medications, but doing therapy, there's such a need as well, and kind of getting people in there too. So I'm going to say too that, Stephanie, that you probably, I think you saw the need, but maybe you kind of also, there was something internal that kind of drew you towards that practice or that intervention as well.
I do. I see, and I think a lot of it, life experiences of myself, not being a super young person, and that was what I think, prepared me more than anything to do it. But and I found myself, primarily the people that I do more psychotherapy with, I would say, are younger women, and who are, I would say, almost kind of the age of my own daughters, in that category, or a little bit younger, and then women my age. And, there's just, it's the need really that drove me, and just, hearing people's stories and hoping that even in some small way, just by listening and responding appropriately, I can help them move forward, even if it's just a little bit every now and then.
That's awesome. Yeah. We've had our students on campus here, and we're doing kind of some foundational communication. That's one of the the themes that we always say, that intervention of just being heard sometimes is so powerful. It's more powerful than any medication I think I can prescribe. But I will offer this opportunity to you as well, Stephanie. I'm terrible at this. My wife will definitely say this. I'm terrible introducing people. So maybe kind of a quick opportunity to introduce yourself. Yeah, that would be great.
So I've been a nurse for 40 years and went back to graduate school in my 40s. Initially was a family nurse practitioner. So I've been, in love with the hospital. So this is really a change for me. But did a kind of an acute care position. But then it was really when I moved more into doing more of a family focus. And it was really the free clinic that drove me in this direction. So I went back. I felt I was going to the free clinic, that the mental health needs were staggering. I felt quite inept, to be honest with you. So that drove me to go back for postgraduate. So now we have started our program, and so it's exciting though. Just the needs everywhere. You see them. I mean, that's one of my things is in primary care. Wow, there is so much to it, and you just feel kind of ill-equipped in this area.
Awesome. Thank you. And you're with Mercer University, right?
I'm full-time faculty, and I practice one day a week in psych mental health, and I do some other things too. My other interests are global health and underserved population. So I take students to India every year for 3 weeks.
Oh, wonderful. Oh, that's amazing.
Yeah.
That's great. Yes, I'm the current president of the International Society of Psych Nurses. And so we have an affiliation with I think it's the India Society of Psych Nurses. So so we have continued relationship with them, but that's amazing. Thank you for that work that you do. So Humberto, I don't mean to ignore you. I would love your perspective on that question. When did you get interested?
No.
Yeah.
Yeah. So similarly to Stephanie, kind of grew into, not necessarily pushed into. So I coordinate the NP programs at Mercer. So Stephanie and I work together. She is the lead for the psych mental health track, which we just started. We're just graduating our first cohort and super excited to meet that need. Yeah. Because Georgia does have a shortage similar to other states of providers, specifically psychiatric, like mental health providers in the state. So really trying to step up and fill that need. My background is completely different. I'm emergency nurse practitioner, emergency nurse. I was a clerk, a tech, kind of went up the ranks through the ER. Not to date. We just observed September 11th, but that was kind of the catalyst to that got me interested in nursing and kind of pushed me into that service. And I gravitated towards the ER. That adrenaline, kind of fueled me for a couple of decades. And then as time came by, I just, especially after COVID, I just felt that there was a huge need in that mental health space with substance abuse as well as just mental health overall. And even though I felt like I wanted to flex some of that therapeutic communication and some of those basic nursing skills that we have, a lot of the times it was just the demand that kept me from really sitting and talking to patients and getting to know and just being present, right? We talked about being therapeutic in our communication, but I think also that presence also speaks volumes. And sometimes patients just need that space to be able to kind of open up and then just also have someone to hear their story. So I, similarly to Stephanie, in preparation for the psych mental health track, went back and got my postmaster's certificate and have been practicing here in Georgia. We have our full-time academic responsibilities, but then we're also able to practice and give back to the community. So in my current practice, I see patients that are in recovery, that are in partial hospitalization, intensive outpatient type of like setting, and then some virtual visits as well, to try to do that med management. And I think that that's really where our specialty definitely comes into play, especially given the family nurse practitioner, like that medical knowledge that we've practiced like for so many years, and seeing the interplay of like some of those medications on mental health. But I have noticed in my current role how patients do benefit from that therapeutic alliance, and that ability to share that space to be able to go ahead and like tell the story. And sometimes they just need someone to kind of listen, and point out those coping skills, those positive as well as sometimes those negative like coping skills, and to get them on the path of recovery and feeling better about themselves, right? Yeah, that's kind of what has drawn me, and I've really been grateful for the opportunity to kind of spend that time with the patients that I'm currently like working with.
Thank you. Yeah. No, I don't know if even Melissa knows this. I mean, I spend a little time in the ER myself. It's not as long as you, and so definitely not that level of expertise. But as an RN, I was kind of drawn to it. It was, there was, for me, the duality of it, because in psych, it's a lot about seeing small changes over time, right? It's and sometimes we have to really look hard for those changes that we see. Whereas kind of with the ER, it was a nice kind of balance of kind of that. I hope it can say this, that street and treat and street kind of thing where you get in, you provide some quick interventions, and then you move on to the next level of care or sort of thing. So I really like that duality, but I obviously kind of continue to be drawn more to this kind of relational kind of role and such. But no, it's thank you for sharing that and really kind of seeing where that goes. I'm going to turn it over to Melissa now for the next question. Thanks.
Thank you. Yes, it's nice to hear how you have your academic duties as well as you're able to practice and give back to the community. We'd love to hear a little bit either about the first time that you performed psychotherapy, if it was memorable, because often it may be, or if there's a session that really taught you something, you could opt for that too, which may not be, your first session. And either one of you can jump in, I suppose, Stephanie or Humberto.
I'm going to say this is not just one session, but it was the first person I had a long-term relationship with that we actually met, not for just medication management, but for psychotherapy every week. And it wasn't, I think at first when she started sharing, I was like, oh, I felt overwhelmed myself. Do I even know where to go with this? But over time, with that constant development of our relationship, my life experience and me doing some reading, I felt we began to move forward. And but it wasn't until, a year and a half into it that one day I sat down and I looked at her in my life where she's at. And I looked back a year and a half ago and I was like, wow. Because like you say, the steps seem very small. And sometimes when you're doing that, you feel like, am I getting anywhere? Are they moving forward? Am I helping them? And then it was amazing to look back and see, wow, we have come so far in a year and a half. And we reached a point about 2.5 years into this that I got her to move to somebody else because I thought it was time, not because we weren't doing well, but I thought it was time for a new perspective for her. But we still talk for medication management, and but it was there's a couple of instances like that. When I first thought, I don't know if I can do this. And then as I really, with her, I started, listening to her story. I went and read the CODA book, the Codependence Anonymous book, to try to get myself really engaged in what she was doing. That was part of my own personal education with that particular patient. But I learned, the other thing is I learned so much from my patients.
Yeah.
I
Yeah.
learned so much from
That's what I love about this role too. And yeah, that made me think of, a time too when I worked with a patient that was in a nursing home and same kind of thing. It was, kind of working with her and just kind of wondering after each session, what did I do? And did I do anything that was anything positive? But yeah, over time you kind of look back and you're like, oh wow, yeah, we did make some changes. So thanks, Stephanie. That's great.
So I guess one theme that stands out. I do have an example of a patient that I've been able to follow through now for a good 6 or 7 months. The patients do at times get confused on the role of the NP. This is common in the emergency room as well as like common as a psych nurse practitioner, where they're not sure exactly what services you're able to provide. So I've had patients that have actually come for therapy specifically, and when I tell them that's not really like my area of strength, that is an area that I do practice, and we can definitely offer like some talk therapy, and we can talk about like cognitive behavioral therapy and so forth. That's not my area where I really like flex. My area is like that med management, and the two I try to get the patients to understand the two complement each other, as like the medication management is one piece of that puzzle, and then the therapy is the other piece of the puzzle. But like Stephanie said, that sometimes the patients are not able to really find therapists. They're not able to meet the financial restraints, and they only are able to go ahead and like pick one. So I think for the psychiatric nurse practitioners, and this is what we tell our students, it's an area of opportunity that you're able to connect. And there are some students that gravitate towards that area because they have a background in teaching, they have a background in psychology. But I do see that misconception with patients and not knowing their role. And I think that in nursing, we at times create more confusion with the different tracks, the different roles, and so forth. So I try to educate the patients, and in that same vein, see that as an opportunity to talk about like what really brought them to seek treatment. And at times, like I've mentioned, just being able to voice some of those concerns. With this one patient that I met who had anxiety, depression, had gone through a number of transitions, life changes that really brought together a lot of strain in her life. She wasn't necessarily in crisis, but there was that like overly anxious, like panicky, like feelings and sensations when I met with her, and just being able to sit with her for that hour for the intake to kind of unravel some of those patterns, some of those processes. And I remember having a conversation with her about some of those common coping skills that might have worked back in the day, but at this point in time did not really suffice. And after talking to her about how this event in her life has kind of derailed, and what the need of learning new coping skills so that she is able to really meet the demands that are being made of her at this point in time, from financial to like interpersonal and like so forth. And there was a bit of an aha moment for her because that was her comfort zone. So the comfort zone was like, this is how I took care of things in the past. And that's what I see with patients that are in their recovery journey. They tend to just got to go to that comfort. And with therapy, the talk therapy and like the sessions that I have with like patients, they are able to at times identify that was how I dealt with things then. And now I need to be able to learn new ways that might be uncomfortable. They're outside my comfort zone, but I'm going to be able to probably augment those coping skills and not necessarily rely so heavily on those that didn't work for me in the past. So I've had those aha moments with patients, which I've enjoyed, which in the emergency room, obviously, it's like you said, treat them and treat them. With my current role, I'm able to actually carve out some time and really hear the patient. And yes, there's that medication piece. And we had suggested different medication regimens to kind of help with her feelings of panic and so forth. But just being able to meet with her throughout the last 6 or 7 months, monitor the medication and the efficacy of the medication, but then also just have those touch points of how are we with those coping skills, getting her connected in the community, getting her the support that she needs, not just for housing, work and so forth. We work through a lot. So I think that is one story that kind of stands out as an example of how therapy, I think, is a powerful tool.
For some reason, thank you both for sharing. The metaphor of a bridge came to mind as you're talking, helping patients navigate previous coping skills and seeing how that's not working and sort of building that bridge to new ways of navigating their life and their challenges. Thank you.
Yeah.
Yeah, I like that, Melissa. It's I was also thinking that it's, this is a process, right? One of my first, mentors in my career, she would talk about that. Actually, her mentor, which I still would like to do, had above her door, and it was in Latin, so kind of no one knew what actually you said, but it was always trust the process. Because I think that is a challenge, whatever kind of role we're playing, using as PMHNPs, whether we're focused on medication management or we're doing therapy or we're doing some combination between the two. It is, it's hopefully it's reassuring for people to hear, especially new practitioners. There is going to be a lot of times where you're going to feel like you're not doing very much and you're really kind of feeling as lost sometimes as the patient. And so, I think that's always a call out to make sure that we're, leaning on our professional networks. And like we talked about earlier, when we met at a conference, and kind of connect with people. It's surprising, but every conference that I've gone to, I've always found somebody who has very similar experiences or struggles that I have as well. So it's just gotta kind of go up and do the hard thing of introducing yourself and meeting some people. So yeah. So it's, the next question, kind of get a little bit more globally. So we kind of ask you more kind of personally, kind of your experience with therapy and things. But now I'm going to kind of ask you, what do you see as nursing kind of being a leader? Obviously, psychotherapy is done by multiple professions, psychologists, social workers, other professions out there too. But, what is nursing? How do you guys see nursing being a leader in doing psychotherapy? Or just leave it there.
I think nursing has such a global approach, and we are looking at, I think, the background of nursing, looking at the whole person is, such a great starting place. I think the heart of nursing, I don't know that we are taking a leadership role, but I think we can. I think nursing are the ones, if you look at, underserved populations and you look at free clinics and all that, the people who are the providers in these types of underserved areas are typically nurse practitioners mostly. So I think we're the ones out there, seeing this, doing this, and where to go with it, I don't know. But I think the heart of what we do, I think we're ideally suited to move forward. There's so much that needs to be done, even from a policy standpoint in this arena.
And I would say, to kind of put a plug in, Pat Lau, who this podcast is named after, right? She is the mother of psych nursing, and her theory of interpersonal relationships is kind of like the basis of that nurse patient relationship, right? Where everything is kind of like built on. Nursing is identified as the most caring profession. And I think it's because the nurses are at that bedside and are able to hear the patients. And sometimes it's just that presence. Like I said, now we have the capacity to be present virtually, right? From different parts of the world. But even just being on that screen or being next to that patient, like holding their hands, that is a therapeutic and powerful experience where people sometimes just need to have someone listen. And what I find is in my current practice, a lot of patients are in an island. They feel that they're alone, that nobody can get to that island, and sometimes by connecting with you, you're given like that bridge, or you're given that opportunity to like listen to their story and can kind of help unravel some of those concerns. And yes, there is a place for medications. We know that there's advances, and we know that the realm of like pharmacology has completely like revolutionized like the treatment approach for psych patients. But I think also at times as nurses we have to go back to the basics, and listening to the patients, having that patient-centered approach is kind of like the basis of what we do.
Yeah. Yeah, thank you, Humberto, for mentioning Peplau. Obviously, yeah, that's kind of the model here. But I think I totally agree with what both of you say, and I think that I love this idea. Yeah, just kind of remembering that nursing is a very holistic, perspective, and so we can offer medications, we can offer therapy, we can kind of, and again, I think from my perspective, as psych mental health nurses, I think we're skilled at kind of knowing where, because I think that still comes a question, what patients need just therapy, what patients just need medications, and things like that too. But even like you're saying, Humberto, like the idea of medications and they keep advancing, and, meds save lives. I mean, you can't not argue that basically, but it's, meds only do so much and they only work if a patient takes them. Right. And so I still think there needs to be that therapeutic alliance, that patient trusts you, and they kind of believe that, I'm going to prescribe this medication, where the pharmacist is going to give them, an arm's length of side effects that could happen.
Yeah.
And, and sometimes you can say, don't read that at all, or however you want to kind of approach that. But it is about that trust and about that, that person heard me. And that's what I hear a lot more too, is, when you talk about different professions and people coming to you and like, finally someone listened to me, someone I felt heard, as we were talking earlier too. So yeah, thank you for those perspectives. That's great. I think Melissa's going to kind of get us on our last question here.
Yes.
Sure.
And I love metaphors. So thanks for the island metaphor. That's so powerful. That really resonated. Yeah. So the last question is, what do you each see as the future of psychotherapy for PMHNP?
I think it's going to expand, but I think, we are going to need to provide more education in that. And, currently, as you do give education in psychotherapy, but most places are really trying to make sure that they understand the different kinds of psychotherapy and have this global view. And we focus on motivational interviewing in ours. But I think the need for additional growth and education in that area is going to be very great, because I think it's going to become more and more common. Barriers are insurance payments. that whoever you're working for doesn't want you to do psychotherapy often because they can't bill enough, which is very sad state of affairs. But I think it's going to become more and more because you cannot help but see the need when you're talking to individuals, even if you're seeing them from med management, you cannot. And that's how you kind of fall into it. So, but I think further education, I would love to see, we're seeing a little bit of it, to be able to go to a conference and, all right, let's do a 2-hour course on, CBT, just, I think nurse practitioners are going to seek more education because they're going to be like me and they're going to be like, oh, wow. Okay, now what? Let me read a book, So.
Yeah, no, I agree. And Steph, if I could kind of just follow up with that, do you have, or can you think of any examples? Like, I totally agree with you. This insurance thing is unfortunate pushback. And I think there's a misconception out there. I personally believe there's a misconception that doing therapy is somehow financially disadvantaged. I think there's a way to kind of use double book, coding and things like that. But is there any examples that you've had that somebody pushed back on you, that saying you couldn't do, what you thought was best, and you kind of were able to kind of push back and have a little, maybe we'll say a victory of some sort? Do you remember?
Oh yeah. I guess my biggest challenge is with the office manager. They always think that they're the boss. And so not all of them, I shouldn't put them out. But, in saying and scheduling me for short appointments and then bugging me if I went over, and me having to say, look, this person needs more than 15, 20 minutes, well, we're not coding for that. I'm like, well, code for it, because that's what I'm going to do. But then I was constantly doing workarounds, and the one I'm describing that I saw every week for an hour, I never got paid for that, so I guess I got paid once a month for it, but I know there's probably better workarounds than that. But yeah, I think, and then that's why Humberto and I talk all the time. We just need to do our own thing because we want to do it the way we want to do it and feel like it should be done, versus sometimes working for somebody. So.
I love it. I always say that, an advanced practice nurse has a little bit of ODD when that's, that little oppositional defiant where you just kind of, you push back on that system every once in a while. So thank you for sharing that.
And I would just say, from the academic side, right? So Stephanie and I have our lived experience, and we're trying to share that with the new generation, those that are stepping up and really starting their journey and meeting the demands of the community and those patients. We try and expose. So part of our curriculum includes psychotherapy, and she and I, as we were mapping the curriculum and creating the Psych NP track, kind of wrestled like how do we include this? No, we need to make sure that they know X, Y, and Z. And yes, we would love to expand on the therapeutic portion, but we're also limited to the amount of like credit hours and what we can offer in that short semester and in that short program. What we've tried to do is kind of thread some of those therapeutic modalities throughout, so that they're not just exposed and it's like, I'm going to remember this for the test and I'm not going to go ahead and apply it. We've been able to successfully, I think, introduce it, reinforce it, and then also highlight it in some of the assignments that they do in clinical, so that they're able to really appreciate the approach and see those patients that therapy does benefit, right? And in my current practice, we work with specialists in EMDR and CBT, and we're all familiar with like motivational interviewing and so forth. So there are success stories for patients and exposing students that are probably just comfortable with the meds and that's their comfort zone, and saying like take a step back. Let's look at the patient as a whole and how can we support the patient and have a more global approach on their mental health. And we've been surprised that students do gravitate, and through some of our on-campus activities where we have like standardized patients that they have to kind of interview and use some of that therapeutic communication. We've been surprised that students do feel comfortable and are actually able to role play some of those experiences that they've learned in clinical as well as in the classroom.
Love it. Thank you. That's so great. I mean, it's. I think there's just these kind of common themes of if we're kind of going like Melissa with the metaphors. I'm thinking like sticking your toe in, just kind of just feeling how the water is. It's like, oh, that's okay. I can probably do that. And then like you said too, get more education. Look for programs that have that in their curriculum.
Yep.
And then once you get out, obviously you got to start getting some more expertise in things, as you mentioned, like Stephanie, and kind of the work you've done as well. So again, thank you so much. We're kind of pushing up on time, so appreciate this as so much for Humberto and Stephanie from Mercer University to join us on this episode of PepLouse Goes. As always, if you've made it this far, that's great. Please like, subscribe, put comments. Contact for Humberto and Stephanie will be in the notes as well. But look forward to having another episode coming out soon, and have a wonderful day and weekend. Take care. Bye.
Emotional reasoning, too much salt like this, too much seasoning. They feel it, therefore it's true. Work hard until those thoughts are finally leaving, so you can be you. They feel it, therefore it's true. Work hard until those thoughts are finally leaving, so you can be you. Guided discovery, identifying, challenging your beliefs. Reframing your mind, negative thoughts release. Let it go. These cognitive distortions decrease until they cease. Yeah, guided discovery. Identifying, challenging your beliefs. Reframing your mind, negative thoughts release. Let it go. These cognitive distortions decrease until they cease.